society. So how do we deal with that? And you should know that we've created an action framework for the state to plan for well-being, which I hope you will think about as you deliberate on your legislation. We really need communities to work together on this. We need to make sure that our children have a strong start. So we're going to talk about the neonatal abstinence syndrome as part of that. And we have to do prevention. Our systems of care have to work together like we're collaborating at the state level. So I want to show you some maps of the harm. First with hepatitis C, which I have described publicly as a tsunami entering the Commonwealth. The way this map shows you is entering the Commonwealth from the southwest. Nothing negative about the people in the southwest, but they're dealing with tremendous addiction crisis, and a subsequent chronic component of this is hepatitis C, unintentionally picked up through injection. This is, you now know we have treatment. Each treatment course is about $90,000, and we have seen a tremendous increase in numbers. The numbers I'm going to tell you are a tremendous underestimate. 2010, we had about 2,800 cases. In 2015, we have over 8,000 cases, and then I can tell you there are many more that go unreported. So this is a looming issue for all of us, not just the individuals, but we're all going to pay this bill, and we have some significant ethical issues as we try to figure out how to assure treatment. Then we have HIV, which we've had for a while. You'll notice this map is different. This is new cases of HIV. And what we're trying to prevent is what happened in Scott County, Indiana, where our current vice president-elect actually passed a legislation similar to what you will see to assure that we stop the spread of HIV as a result of the injection drug use that was going on there. They had an unprecedented HIV epidemic in a very small rural town. We're poised for that to happen, probably most likely in southwest Pennsylvania, Virginia. I'm in Virginia. And then lastly, we have kind of the innocent bystander here, the neonates. And what you're seeing here is specifically looking at the Southwest, but I'll tell you for the past 5 years, the rate of neonatal abstinence syndrome, these are babies who are born addicted and withdrawing, has increased fivefold in Virginia, fivefold. In 2014, the last year I have full data for, 542 babies were born with neonatal abstinence syndrome. That is not assuring a strong start for our children in Virginia. And in fact, the cost in 2014, because the Secretary said who's going to pay for this, over $28 million to care for those 542. $28 million. So this is preventable. It is preventable. And to do so, I would ask you this. For this problem, this complex problem, if we had a solution that was proven effective to prevent the complications, similar to what I'm talking about here, if it didn't worsen the condition, and in fact, for those who participated, they were 5 times more likely to get the actual treatment that they needed. And by the way, it reduced overall health care costs and complications. Would you support it? Because you're going to see legislation about that for comprehensive harm reduction. One of our neighboring jurisdictions did just that. In a 2-year period, they averted 120 cases of HIV. Estimated savings for that alone is $44 million. $44 million. We have, most of our neighbors now have comprehensive harm reduction legislation that you will see. North Carolina just passed it last year. I would urge you to look closely at that and look at these issues. These are, if they haven't hit you yet, they're coming, and they will affect all of us. You've heard the stories. I think you probably all know somebody now who's been affected by the disease, the chronic disease of addiction. And it is a public health emergency, and I don't want us to lose anybody else. Thank you.
We thank Dr. O'Bannon for those bills over the last few years to help with that. Dr. Barber would like to talk a little bit about treatment, and I will add treatment workforce is another issue we're working with. We had SAMHSA had a meeting on Monday in Charlottesville, and DCU did. We are trying to develop a curriculum that increases numbers of rehabilitation counselors that are available, and we are very much looking at expanding the amount of expertise in our medical centers through addiction medicine fellowships. But Dr. Barber?
I'm going to be pretty quick. Not such an easy thing. I did want to just skip on a couple of things that have come up before. I had an attending when I was in med school that said, withdrawal from alcohol will kill you. Withdrawal from narcotics, which is what we call them, will make you wish you were dead. So when people get into this, it is extraordinarily uncomfortable and painful, and they will do anything to take something to get out of it. Some of the ways that the treatment helps. You also ask about the path, Delegate Bell. In the 80s, the path to opiate addiction was through illegal drugs, primarily. 75% of the time now, it is through prescription drugs. So we are seeing more, and we're seeing a new path. And all of you have probably been in the hospital or seen a healthcare worker in the last 10 or 15 years, and they're asking you all the time about your pain, right? What's your pain? Could you describe it? Point to the smiley faces. That comes from the Joint Commission on Healthcare that regulates our hospitals and practices. And what do doctors do? They try to relieve your pain, and so here we are. MAT, effective from the standpoint of reducing overdoses, putting a foundation under people's lives so they can go to work, repair their relationships, and try to build a bridge, greatly decreasing the risk of HIV, decreasing the risk of hepatitis C, which Dr. Levine was talking about. There's a lot of co-occurrence with individuals with mental illness, behavioral health disorder, and addiction, trauma, just as you heard. One of the things that I wanted to highlight is, you know, when you're in the hole, you need to stop digging the hole. So some of the regulations coming out of health professions, prescribing guidelines are meant to prevent new addicts by not hooking people in the beginning, and that's a change in medical practice because this is a hard illness to treat. It's a lot better if people don't get it, so those efforts are really important. Some of the other harm reduction packages. So MAT, safe and effective co-occurrence. The governor's proposed budget has $5 million to treat 1,000 or more individuals. The treatment is not cheap. Medication-assisted treatment with Suboxone is up to $1,000 a month. Can be less or more depending on the dose. Methadone is a lot cheaper, $1,000 a month, but those are very highly regulated places. They have their own sets of difficulties. Naltrexone is like $1,350 a month. That's an injectable. So the treatment is not cheap, and it's one of the reasons we have so many people untreated. Peer services, huge development in this area and others. And as Dr. Brown was talking about, we now have access to Medicaid reimbursement and regulated by the Department of Health Professions. These are folks who can reach people that professionals can't. They just can't. Their lived experience allows them to connect with individuals in a way that we can't do it. It's been proven very effective in improving relationships, job productivity, decreasing overdoses. A lot of evidence for that. The last thing I want to mention is the Revive trainings, and that's how you save people's lives with naloxone. There's money in the governor's budget, really so that people can be trained and actually walk out of the training with the stuff. So it's great to be trained, but it's $50, $80 to buy the thing, and a lot of lay people can't afford that, and to make sure all our first responders have it. That's about as fast as I can.
Thank you.
You know, there's so much more to say.
Thank you. He does, but I'm stopping him.
Now we're politicians.
Now we're going to give you the slow version from Carl Ayers from Social Service, but Kate Newhausen from BMAS will follow and make up on the speed talk. Mr. Ayers.
Good morning, Carl.
Good morning, and it's my pleasure to be back with you again. And speaking a little bit, as you heard Dr. Levine speak to, these are the innocent bystanders that are affected by the addiction issue that we're talking about here. These are as up to date as I can get you through July of this past year. You will see we had a 21% increase in substance abuse newborns last year. So we dealt with 1,334 children that were specifically reported to us by substance exposed newborns. And then I even broke it down for you even further by region. So you can see by region specifically where these children are coming from. What you will notice is that Northern Virginia, of course, in the Fairfax area, is our most populous area. But Piedmont, which is the Roanoke area for the Department of Social Services, is one of our substance is something they can't control before their birth. Through the process, a lot of them are treated with morphine. So what do? Is you then take another drug that takes months and months and months to wean them off the drugs that they were exposed to in utero. So it's a very difficult process, it's a very challenging process, and what our responsibility is to try to support the mother, generally is the one that was substance abusing, to support her in her treatment, and to make sure that we are protecting that newborn baby. Because as I'm going to show you on the next slide, these children are dying. And so we had 7 child fatalities in the last year that were specific to substance-exposed newborns. What I will tell you is that not a single one of them died from the substance exposure. What they died from was from the lack of care that they got whenever they came home. So what we have to do a better job as a system is connecting the dots, making sure the mother is taken care of, making sure the child is protected, and making sure that the services are provided from both ends of it. So what you're going to see is you're going to have legislation that is being introduced in both the Senate and the House this year for us to do a better job of providing services to the mother, identifying these children, and making sure that the child is protected at the same time. So specifically, Delia Solly, who has already left from that end of it, is carrying the House version, and Senator Wexton is carrying the Senate version. We added a new categories of our system last year to begin tracking children that are coming in specifically for substance exposure. And so we had 80 children that came into foster care that we had to remove from their homes, only for substance exposure. So that is a new piece, and I want to make that point to you because you look at the 1,336 or 1,334, we are keeping children and families together. We are serving mothers, we are keeping children protected, but there are circumstances where we can't do that, and they have to come in and they have a cost to their system as well. So that's my quick version from that end of it. So.
You've done good, Mr. Harris, thank you. Dr. Newhousen, speak, talk, and
Doc, let me just interrupt you real quick. Senator Donovan, did you have a question?
Just one tiny nuance. If we go back to that slide and we say that 80 children were put in foster care because they were substance-exposed infants, but probably that was the variable that brought them to your attention. But there's another reason that they didn't go home with moms, right?
Correct. This is the removal reason. The primary removal reason that they were brought into care was because they were substance exposed.
not just infants.
Correct. Substance exposed newborns can be diagnosed up to 6 weeks after the child is born. But specifically, there are going to be multiple factors for why that child comes in. We have a primary reason. It is almost always comorbidity, the mental health issues, any other multiple pieces that come along with it. But that was listed as the primary reason that they had to be removed.
And that's going to cause alarm if we up our reporting rates. And it's going to maybe obstruct people revealing that they are using. Just saying we may want to change that language because the reason wasn't just.
Well, and actually, as I connected for you, what I was trying to say is we have, the question had been brought to me. No, we're going to be removing more children. No, what I want you to see is that I did 1,334, but only a little percentage were actually brought into the home. We were able to maintain the vast majority of children in the home.
Thank you. Dr. Newhousen, Major Settle, you're on deck.
Thank you, Mr. Chairman and members of the committees. The initiative I'll present on today is part of the Medicaid Addiction and Recovery Treatment Services Benefit, known as ARTS. This was formerly known as the Substance Use Disorder Treatment Benefit, SUD. And I would like to thank all of you for investing $11 million last session to provide comprehensive addiction treatment to our 1.1 million Medicaid members. Because you all funded this benefit, Virginia was only the 3rd state in the nation to be awarded a substance use delivery system transformation waiver by CMS. This waiver will allow Virginia to draw down new federal matching Medicaid funds to expand residential treatment capacity for all Virginians. Since our waiver was approved in December, over 50 providers, including CSBs, hospitals, and private providers, have applied to become credentialed by the health plans as residential treatment facilities. So due to your $11 million investment, these facilities are opening new beds, opening new facilities, and this will provide life-saving treatment to all Virginians, not just Medicaid members. We've already heard of commercial plans that won't have to send our Virginians to California because we will have treatment in Virginia due to this benefit. I would also like to recognize the Medicaid health plans. Since the General Assembly decided to carve this benefit into managed care, we have had unprecedented collaboration with all our health plans and our providers to develop and implement this robust benefit, which will go live statewide on April 1st. So our initiative to reduce opioid prescriptions, which I'll discuss today, is a collaboration with DHP, VDH, MSV, and all our Medicaid health plans. On July 1st, 2016, we implemented the national CDC guidelines for opioid prescribing in Medicaid fee-for-service. And first, this means we've removed prior authorizations for all non-opioid prescriptions, for non-opioid pain relievers. This means as a family physician, I can write a prescription for a lidocaine patch as easily as for OxyContin. Second, required prescribers to check the prescription monitoring program and a urine drug screen before covering a short-acting opioid for greater than 14 days or a long-acting opioid. These charts show that in the 3 months after we implemented these policies, the blue bar, compared to the 3 months prior, the yellow bar, the total pills dispensed decreased by over 50%. Our Medicaid spend also decreased by nearly 50%. But the number of members prescribed an opioid only decreased by 12%. So this means that prescribers are decreasing the number of pills they prescribe to a member, which lowers the risk of a fatal overdose, not cutting patients off opioids, which could potentially lead to increased use of heroin. So we have worked with MSV, DHP, VDH, and all the Medicaid health plans to implement the same policies in Medicaid managed care plans on December 1st for new opioid starts. The Medicaid plans are waiting to implement the guidelines for patients on existing opioid treatment until April 1st, when ARTS goes live, so members don't switch to heroin because they can finally obtain treatment. This is important because 75% of our 1.1 million members are in managed care, so once these policies are in place, we expect to see the same findings to decrease the supply of pills, prevent deaths, and save Medicaid dollars on an even greater scale. And we are also encouraging the commercial plans to implement the same policies because, as you all know, the opioid crisis affects the commercially insured as well as Medicaid. And really, this is, as you know, this is a crisis that crosses geographic and socioeconomic class lines, and DMAS is proud to be part of the comprehensive response to this crisis that is being led by Secretary Hazel and Secretary Moran. Thank you.
And last, we have Major Gary Settle from the Virginia State Police, and the State Police and our law enforcement colleagues have been good partners in our effort to develop community coalitions to get the word out and to address this problem. So, Major Settle.
Thank you, Mr. Secretary. Mr. Chairman, members of the committee, I'll be brief and try to hit the highlights with regards to law enforcement and what we are doing collectively. You'll see here just a few bullet points with regards to what the law enforcement community is doing. You think of, well, we're around here arresting folks. Well, certainly that's part of our part of what we do, but we are also involved in some of the educational programs, and I would say quite a few educational programs that talk about our experiences. And that's to the private and public sectors. Of course, we're with the PMP program, we utilize that to further investigations to look at the disbursements of prescriptions with regards to targets that we're looking into. Of course, the working relationships with the law enforcement partners is critical. We cannot do this alone. This is our federal partners, our Commonwealth Attorney's offices, our U.S. Attorney offices, and again, our three other federal partners as well that work alongside us. The Narcan, our task forces that we have, and I'm going to get to that in just a minute, kind of give you a footprint of what is going on in Virginia with regards to task force footprint. Narcan is those folks are equipped with that, which is important for us, not only for officer safety, but also to help save lives. Launched heroin initiatives, which kind of dovetails into the next bullet point, building coalitions. I'll show you 3 examples of what's going on across Virginia, and you've heard about some of these, I'm sure. But this has received some momentum, and it is continuing to build on that. In Virginia, we have 32 multi-jurisdictional task forces, and that includes 144 local jurisdictions, as you can see. State police supervisors 32 multi-jurisdictional task forces. But I will tell you, we cannot do that without the help of our sheriffs and our chiefs who give us personnel for that task force. We give them state police authority, train them, and again, it's a force multiplier, if you will. The 22 federal task forces, that's your DEA, HSI, DHS, FBI, going on and on. A lot of those are human trafficking task forces, maybe a cyber task force, but all roads seem to lead back to some kind of narcotic. Of course, the suit du jour, or narcotic du jour, it's heroin these days, and opioid abuse. Here you will see kind of a footprint of what is in place in Virginia. The boxes you see on the outside represent a specific task force. And the counties and or cities that belong to them, that's a tough read. You kind of had to squeeze that all on one slide. Certainly, if you have any questions about what's in your particular region, I'd be more glad to talk to you about that. State Police has 7 divisions, and you can see that's represented by a different color on the state of the map. Here you will see, you heard me talk about our partnership with our federal folks. This is some HIDTA designated areas across the state of Virginia. The color, the yellow colors on the map there represent HIDTA designated counties and or cities. The most recent one's up in the far northwest in Frederick County. Of course, we've been working on that for the last 3 or 4 years, and that finally came to fruition this year. Of course, southwest is the Appalachian HIDTA. Senator Carrick, you're much aware of that, obviously. The other, of course, Salem is part of, you'll see that kind of lone little yellow spot there in the Salem area. From there north, all of that is the Washington-Baltimore HIDTA. And what HIDTA brings to the table with regards to the law enforcement component of it, it provides us intelligence, deconfliction. They have the tools and the applications that can help mitigate and massage some of the intelligence we have. It helps us with threat assessment, officer safety, and more importantly, case support to target some of these drug trafficking organizations. And they also bring some federal funding, which is nice. We talked about interdiction earlier. You know, our goal was to stop this narcotic, any illegal narcotic, from coming into the Commonwealth. We'd like to do that across the country. I think that's everyone's ultimate goal. But here in Virginia, we certainly are in tune with this. You'll see here just a photograph. This is almost just $1 million worth of heroin that was interdicted in 2016. I can't get into specifics of that. It's still a little fluid with regards to the case. But you can see that had a nexus to Virginia. Goes to the reason we're here. Another concealment method that makes it tough on law enforcement. This is a transmission that was transported in a vehicle in the back of a van. You can see that narcotics stored in the center part of that. Here's another trunk of a car that is stocked full of heroin in Virginia. That's about 1.5 years, probably almost 2 years ago now. I'll dovetail into another resource intense effort by law enforcement. State Police has the public transportation team, and it also has which deals with the postal issue. We're getting a lot of our narcotics distributed in Virginia or brought into Virginia through the Postal Service. You can see here, these are all, you see the box there in the middle picture there, all that in those type of boxes. They come in, we get a call, the dogs alert on it, and we take it from there. All of these have a nexus to Virginia. You heard earlier about the fentanyl and the carfentanil. We are seeing that, obviously. We're really concerned with that, and I'll tell you primarily from an officer safety standpoint. When we see these drugs, or we seize them, or we think that we have carfentanil or fentanyl or any analog of that, it's not like the traditional pick it up, package, and seize it, and take it to the lab. We can't do that now. Obviously, we're going to seize it, but there's a safety protocol in place now which kind of delays us finding out as law enforcement whether or not it absolutely has fentanyl or carfentanil laced with that particular drug that we're dealing with. We need that information for strategy, deployment of resources, for follow-up, for intel, and I can go on and on and on. So it's that delay could mean the difference of intercepting that $1 million worth of heroin and coming down 95, or a postal parcel package coming in that has fentanyl shipped from, say, China. And I'll talk about, well, here you see the dark web. That's a huge issue for us as well that we're tackling. That's the technological part of it. The Secretary talked about these folks getting smarter. Well, they are. The encrypted network makes it tough for any kind of tracking or intelligence to be divulged, or we can interdict. So just another little hurdle we have to deal with. Successes that we've had, and I will tell you, and I'll wrap it up with this, the community coalitions, and I'll have 3 slides in ending just to kind of show you what's going on across the Commonwealth, just in 3 locations. And the Governor's Task Force provided a number of recommendations that we as law enforcement could grab a hold of, build on, develop strategies, and partner with all of our folks you see here sitting on the front row, and include our private sector as well.